finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
Hey everybody, welcome back this week. I know it's on your mind, it's COVID, it's Delta, it's what are we thinking? Well, I wish we could bring you that this week, but we are on vacation, and this pre-recorded episode coming to you is a special one, so when we get back, we'll touch on all things COVID. For now, hang in there, and I hope you enjoy this episode. But first this week, a word from our sponsor, which is Locum Story. You're going to love this. It's story time brought to you by locumstory.com, and today we'll be reading One Job, Two Job. One job, two jobs. Red blob, no job. Elective doc, emergency doc. Some in overstock, some out of stock. This doc is too abused. This doc is underused. This doc can't get sick. Say, let's try a brand new trick. For all the docs about to cry, here's an idea you can try. Look into a locum tenens assignment. A really great option, you might find it. Don't forget locums pays much better, and you can find assignments in any type of weather. With all this new info trapped up in your thinker, go to drpodcastnetwork.com locum story and use your mouse to tinker. It's here you'll find the unbiased answers you're after, so you can decide if locum tenens is in your next chapter. Love that. Alrighty, today's guest is Dr. Melissa Red Hoffman. Red, as we like to call her, is an amazing surgeon, an amazing woman. We tried to get this recorded for a long time with a lot of roadblocks and various obstacles on both sides of our paths, but we finally got it done. She is a surgical palliative care physician, and she's board certified trauma surgeon, fellowship trained in surgical critical care and hospice and palliative medicine. She's one of the very few 80-plus surgeons in the United States who's board certified in this. She is a leader in this field and also the co-founder of the Surgical Palliative Care Society, as well as a writer, speaker, and creator of the Surgical Palliative Care podcast. She has an amazing background, an amazing past that actually brought her into medicine. She was a yoga teacher and actually practiced naturopathic medicine, and then transitioned over into conservative medicine after an amazing story, which she'll get into. So we really hope you enjoy this interview with her on palliative care medicine, especially from the surgical side. All right. Hi, Dr. Red, or Red, as I'm going to call you. Welcome to the show. I'm super excited. We finally get to do this because, as we know, there's been a few little bumps along the way with timing on your side and our side. And I think, I don't know, the podcast gods or something didn't want this to happen because it was a little while in coming. But I'm super happy we finally get this done. And our listeners get to hear from you. This is going to be amazing. So thank you so much for being here.
Thanks for having me. I'm so excited to get to chat with you guys.
So there's so many podcast episodes we know that we could do with you. But today we are super excited for you to share with us your journey into becoming a trauma surgeon and heading up surgical palliative care, the podcast you have, and the society you founded. So why don't you start with sharing a little bit about how you became a medical doctor, your past, and where you came from?
Sure. So I always like to say I was born in Brooklyn. That's like my street cred. Born in Brooklyn, raised in New Jersey. I always thought I'd grow up to be a writer, and was kind of on that path. When I was 19 years old, my father was killed by a terrorist in Cairo, Egypt. And that really changed the trajectory of my life. Such a sudden and tragic death at such an age where I think folks really struggle with articulating how they're feeling. And certainly that was definitely part of my story. I just didn't know how to express all of the many emotions I was feeling. And so I think it's very typical, particularly in young women, to really somaticize those emotions. And so that really happened to me. And I ended up getting really sick in my young 20s. And I started going to see I did go to a lot of allopathic physicians, but then I eventually ended up going to a naturopathic physician and an acupuncturist, both of who really helped me by changing my diet and starting some supplements and really trying to make that mind-body connection. And so I was in undergrad at the time, and I started thinking about what do I want to do next? And I was very drawn to naturopathic medicine. And so eventually that led me to go to naturopathic medical school in Portland, Oregon, which was just a remarkable journey for me. Yeah. Go Portland, please. But me being me
away.
at some point in that journey, at some point in that journey, I really ended up falling more in love with medicine rather than with a naturopathic medicine. A lot of my friends in naturopathic school became either really skilled at homeopathy or really skilled at botanical medicine or really skilled at physical medicine. And I just ended up getting very interested in women's health and transgender medicine at the time. And in naturopathic school, I also took some time off and went to a yoga teacher training in Thailand for 3 months. And little did we know, we landed in Thailand in the midst of a dengue fever epidemic. And almost everyone in the group got dengue fever. And I don't know if it was like the yoga or the isolated beach we were on or the dengue fever, but everyone who got sick really had a real emotional or spiritual component to that journey. It sounds crazy, but really everyone was going crazy, myself included.
Oh my gosh.
And a lot of my journey was about, am I on the right path? And I felt like, oof, maybe I'm not on the right path. And I got better. I ended up going to India after, and I studied in a truly integrative hospital where medical doctors and homeopaths had been working side by side for decades at that time. And so that was my first real experience with medical doctors. And in the morning, I would be with the homeopathic doctors. And in the afternoon, I rounded with the medical doctors. And I got to be in the operating room for the first time. And that just rocked my world. I mean, I saw a C-section and I was like, I want to be here. It was crazy. The operating room was 90 degrees, which anyone who's a surgeon knows it's usually freezing. I'm usually freezing in there. And also everyone wore flip-flops. It was such a weird environment, but it really, it blew my mind. And so I came back to the United States and I finished naturopathic school with the idea that I think I'm going to apply to medical school and I think I want to be a surgeon. And so that kind of got me started on the next part of my journey. And I was very drawn to trauma surgery, probably because I had great mentors in medical school who were trauma surgeons. And then because of how my father died, I was just so interested in that world. And so when I went to surgical residency, I ended up at a place in Phoenix, Arizona, where there was a lot of trauma, which was great. And I fell in love, not only with trauma, but with sitting in the ICU, which is really where I brought my whole experience of losing my dad and my interest in palliative care, which was really stoked in medical school because OHSU, where I went to medical school, had an amazing palliative care team. And I thought, this is what I want to do. And this is really what I really want to be able to combine my love of surgery, particularly trauma surgery, and then my love of palliative care. And so I did a fellowship in trauma and critical care. And then I ended up doing a second fellowship in hospice and palliative medicine and ended up practicing in Asheville, North Carolina, where I really get to do a great mix of both.
I love this idea of the melding of two worlds. There was a really great book called The Cure for Everything. And the guy was a science, he's actually a lawyer. I forget his name, I'll have to look it up and put it in the show notes, who wrote the book. He's actually a policy lawyer for Alberta, Canada's Medicare. And so he'd read all the studies and do the evidence-based medicine and say, what should we cover? What shouldn't we cover? What's in, what's out? And, he says this, it's all medicine. If it works, it's medicine. If it's not, and he's just kind of coming against this idea of integrative medicine. Like there's this extra thing. Well, there isn't this extra thing. Surgery works really good for some things and not really good for other things. Medications work really good for some things, and diet and meditation and, these other aspects work way better. And it isn't that it's alternative. It's just medicine. We've just ignored an entire portion of medicine in allopathic medicine that's really important. We've become so materialistic. It's like if you can't cure it with a knife, you can't treat it. Or if there's no pill that you can sell, which obviously is a huge issue here, then it doesn't exist. And so I just love this sort of melding of the worlds. I would have never said this at the beginning of my career, because I would have been 100% in the camp of, if we haven't studied it to this degree, then it doesn't exist and it's all hocus pocus. But it's not, because we're really complex beings. And what we actually really know is so tiny compared to what's really there.
Yeah. I too, like, actually, let me just back up and say, I'll just say that what I usually say about that divide between Western and whatever else you want to call it is, the world I work in the hospital, I think we are great at ruling out anything that's going to kill you. And that's often what I'll tell my patients. Like, and there's many times where I don't know what's wrong with you. All I can say is I've ruled out this, and this, and I'm pretty confident about all of that. Where allopathic or Western medicine fails is if you come out negative on all of those tests, then we just tell the patient there's nothing wrong with you. But that's not true. If you don't feel well, there is something wrong with you. Now, it may be on the physical plane, on the mental plane, on the spiritual plane, but just acknowledging, like, I believe that you don't feel good. And so then I'll just often tell patients, either we're going to talk about diet, or I'm going to suggest, like, oh, I know this great massage therapist, or I've been going to this great acupuncturist that I really feel like can help you. And I'll tell patients, like, it is time to, like, look outside this Western medicine box to see now how we can address your symptoms and perhaps even really address, like, the cause of what's going on a much deeper level than allopathic medicine is set up to do. I mean, obviously I love allopathic medicine. That's, that's what pays my, that's like where my paycheck comes from. I love being in the operating room, but we don't have all the answers. And to look at something like Chinese medicine that's been around for thousands and thousands of years, and to say that that is not valid, well, that's so.
Yeah. It's arrogant. And
yeah, it's just,
I think
that's a good word for it.
Yeah. A lot of the time, I love how you say that, I'm there doing urgent care now, but I'll tell patients the same thing. It's like, I'm ruling out the bad things. It's not this, it's not that. I know you don't feel right. Yes, there's something wrong, but there, you might need to see the chiropractor. You might need to see the physical therapist for your back. It's nothing that needs a pill. It becomes a functional issue. Lots of times it's well received. It's interesting. A lot of times it's not, because I think a lot of people have gotten these in the little realm that I've worked in, so used to just going to the doctor and them fixing everything with the pill or the coming up with the answer. And I say it's not fair, because I'm not a dentist either, and I could see that you got an abscessed tooth, and I'm just not trained to do that. So there are other health professionals, whether it's your naturopath, your massage therapist, etc., that can deal with this better than me, and I'm happy to move people on. But it's fascinating how then there's the other side of it, like we're talking about, where there's the whole scope of no, it's Western medicine or nothing, and because things don't have randomized controlled trials, and I don't believe that for a second, obviously. But yeah, it's a whole, I think, amazing to be able to balance things out. And yes, there's times when you need to cut out an appendix that's rotten and you're bleeding to death and you need a trauma surgeon. Then a lot of other times we just need the naturopathic way. Absolutely. And to blend it all
Right.
together.
And I'm not suggesting, like,
yeah.
I'm not suggesting, like, for example, you come in and say we get lucky and we catch your pancreatic cancer at stage 1. I mean, you need surgery. There's no way
Right.
around it. And I would never suggest that, like, oh, this is a great alternative. Let's start you on some herbs. That's not my point.
No.
My point is, when Western medicine either can't find the answer, even though we've tried really hard, or when what we're doing is not working, or that the symptoms that we're causing because of the treatments are just so burdensome, then why not look elsewhere? And why not offer that alternative to patients?
Yeah, I think we're agreeing. We're just saying it differently. At least
Well,
I am.
but I think that the medical industrial complex is a large problem with this, and this is what's absolutely totally pissed me off with regards to kind of where they've put primary care, and with value-based care, we're doing all these metrics and so forth, which have oftentimes nothing to do with what the patient's there for anyways, is this idea that you can do preventative medicine. There's so little that we can do as allopathic physicians that prevent anything. Colonoscopies work pretty good. Mammograms work a little bit, but not great. I mean, there's only so much. Preventative medicine shouldn't be done by us. It should be done by, your friends, by having close relationships, by having a glass of wine with somebody, by going to a personal trainer, by going to a yoga class, by doing, it's all those self-care issues, but we somehow want to medicalize those. And that just, first of all, it cheapens it and it makes it into a commodity, which I hate. But, I work on cars, and I'm not a great mechanic, but I really love it. And, you get the most expensive electric ratchet, and it's such an amazing tool, and it makes so much of the job easier because there's no air hose, and it's got tons of torque, and it's great. But they're not cheap, but they make terrible hammers. Like a hammer is an ancient tool that's still used today because it works so well. And if going for a walk
Right.
and talking to your spouse makes you feel better and makes your life better, which there's tons of evidence that that's the case, you don't need to go see me for however much that costs to tell you that. And this idea
Right.
that we're going to do all this preventative medicine with allopathic medicine. No, I think we should be the sick care model. If you're really sick, you should come to, if you have an acute abdomen, you need a surgeon. You don't need a priest at that point.
Yeah, and we're good at that model.
Friend,
Yeah.
and we're really good at that. And but this idea that somehow we can make healthcare everything for every ill. I mean, when I left a couple organizations ago, they were talking about the social determinants of health, and I was just like, whoa, pump the brakes there. Yeah, you can recognize it and maybe make a referral or something because you see, homelessness or whatever it is. But that's not the healthcare system's job. I mean, that's society's job. That might be there might be a political solution. There might be a community outreach solution, but don't make it healthcare because then it's just going to get more expensive and more
And terrible.
useless. It just drives me crazy.
Right.
So
Yeah. And then less people are going to be able to access it too.
Exactly. Exactly. So tell us and the audience a little bit about this surgical palliative care side of things, because I know a lot of people know about palliative care, but I think a lot of people think of it in terms of grandma or mom has cancer, they're dying a slow death. It's a long thing. You're on hospice and there's palliative care, but surgical palliative care involves some different aspects too, right? So I know that a lot of people have not heard of that side of things. So tell us a little bit about how that works.
Sure. So one thing I really like to talk about when I'm talking about palliative care in general is that I think most people don't realize that the term palliative care was actually coined by a surgeon, Dr. Balfour Mont, who's still alive. He is practiced as a urologic oncologist at the Royal Victoria Hospital in Montreal for many years, and then was really, really influenced by the work of Dr. Elizabeth Kubler-Ross, and ended up studying with the founder of the modern hospice movement, Dame Cicely Saunders, and then coming back and starting this whole inpatient palliative care unit. So I think no, people think they hear I'm a surgeon that does palliative care and they're like, oh, those are two such disparate worlds. And I'm like, no, really, they really make great sense to me. So again, so surgeons really started palliative care. And then I think another thing people don't realize is the first hospices, which is really, a little different than palliative care. A hospice is really reserved only for patients who have 6 months or less to live and are really no longer interested in any disease modifying treatment. Some of the first hospices in the country were actually founded and run by surgeons. So surgeons have been involved in this movement for many, many years. But in the late 1990s and early 2000s, the American College of Surgeons really got interested in palliative care. I think they see that, all of our patients in the hospital are suffering, but certainly I think surgical patients have their own special kind of suffering. One, they're suffering from their disease process, and then two, they're suffering oftentimes after their surgery, particularly if they have complications. And so surgeons became interested in the idea of providing palliative care, which is really that, team-based symptom management given to patients who are dealing with life-limiting or life-threatening illnesses. And, at its best, palliative care is given along disease-modifying treatment. So it's given when you're getting chemotherapy and getting radiation and getting all these surgical procedures, and palliative care is that extra layer of support. And so some surgeons like Dr. Jeff Dunn and Dr. Bob Milch and Dr. Ann Mosenthal started looking at how can we start providing this high quality palliative care to our surgical patients. And so surgical palliative care is really meant to be symptom management and kind of lessening of suffering for patients who are undergoing any sort of surgical care. And within that definition is certainly some palliative surgeries. So part of what I do is, if you come in with like a intestinal, like say metastatic ovarian cancer, and now you have a metastatic, I'm tripping over my words. I apologize. You have some metastatic ovarian cancer and you have a malignant small bowel obstruction, I can certainly do an intestinal bypass on you. Or if you have sort of some gastric outlet obstruction, I can put a PEG tube in you and at least offer you some sort of symptom management. But those palliative surgeries are only part of what we do. Really, we're also trying to do good symptom management and really have those difficult conversations with our patients, about goals of care and code status and making sure that your advanced directives are up to date. And then walking with our patients through everything. That's like through their surgeries, through their possible complications. And then when there's no more surgeries and no more treatments that are fitting your goals of care, then we're walking with you through the end of your life. And to me, that's like the best care that's delivered across multiple settings, delivered really from the emergency department all the way to hospice is the way I really like doing it. And I always tell surgeons, like, we're just set up to do this well. I think that it's in our blood and in our genes to be able to offer this sort of palliation to our patients and also to their families.
Yeah, and that's a massive component. You're not just taking care of one patient. It's the whole, when you start dating somebody and you think you might get married and you talk to your parents about it, and it's always you remember you're marrying the whole family. And
yes,
sometimes that's and it's, I think actually it's sage advice, and it's the same thing. I did obstetrics for 12 years of my family practice, and it was the best part of my family practice. And you didn't just take care of a pregnant woman and then her infant. You took care of the whole family. You made a connection with, grandparents and all of these people. And it was really rich. And, we need to remember that because, medicine gets so compartmentalized and it just kind of dehumanizes things at times,
Mm-hmm. Yeah, absolutely.
I think that word rich is so good because when I think of my practice, it has so much richness in it. And because I get to do this really life-saving sort of procedures in the operating room and in the trauma bay, that feeds part of me, but then being able to be at the bedside while someone's dying, and then being able to sit with their family after and just tell stories about their loved ones, like just the combination of that is so rich. And part of what I realized early on, even in my training, was that like it is okay to cross some of these lines. Like I definitely think, not only is there hierarchy in medicine, but I also believe like in some ways it is important to stay in your own lane. Like, I want to leave the complex cardiology to the cardiologist, but I can do the basics, right? If I'm in the ICU, there's some maneuvers I'm going to do before I consult cardiology. But when it comes to like palliative care and end of life care, I feel like that kind of, we don't need to stay in our lane. Everyone should be engaged in that stuff because all of our patients are suffering and all of them are going to die. And why shouldn't we be intimately involved in that? I mean, one, again, it adds richness. And two, there's not enough palliative care providers in the world to really meet that need. I always look at palliative care. Part of the reason it came about, I think, was because no one else has the time to do this anymore, right? No one really has that hour to sit with their patients. But the reality is we can all do what, we call primary palliative care. We can all do some basic symptom management. We can all have a discussion about code status. We can all discuss some goals of care. We should all know a little bit about how the Medicare hospice benefit works. And then if we get stuck, we have these people who just focus on that. But I think that, to think that like you need a fellowship training to sit with someone while they're dying is, no, you don't. Doctors have been doing that since the beginning of time. That's part of what we do.
Yeah, it really, it is. I love it. It's great to hear somebody, because we've had so many different podcasts we've listened to, or interviewed people where it's like, physician burnout, and it's actually delightful to talk to a physician that's really that still loves their career, and there's a reason for that. You love doing what you do for a reason. You deliberately chose this specialty. You deliberately chose the other, wings off your specialty into palliative care, into some intensive care, and a lot of it comes back to just kind of living deliberately. And, why do we get burned out? And what burned May and I out? Well, eventually, you're doing primary care and you're working for a giant company and you're not managing any of the day-to-day aspects of your life. Well, that burns anybody out. And especially when you're highly educated and highly experienced, then you know what the right thing to do is, and you can't do it because your hands are tied, and so it's, that deliberateness is really awesome. And it's great to hear that there's still joy in medicine. People can still do this job and love it and do a great job and really change people's lives.
Well, and nobody wants somebody doing that job in medicine that hates it. I mean, what's worse than you're dying, you're having complications, the family's grieving, and you got somebody in there that's burnt out, just like, I don't want to be here. I hate my life. And and that's the worst place to suffer burnout and have to work through it. Honestly, but I'm just thinking, still to some of the questions going through my head, and I know people thinking that. So how much of it is like, obviously, I know that there's teams, but I think in the sense of, when we did ICU training a long time ago, the people, I think most people in medicine know that intensivists in ICU are not always just a certain, say, internal medicine doc. There's anesthesiologists that do ICU, pulmonologists, cardiologists, usually certain
Trauma surgeons.
Exactly. We had a trauma. Well, back then it wasn't as much trauma, but we had a surgeon, which was unusual, and we were coming through to have a surgeon as an ICU leader. But yes, so absolutely. How much in palliative care then is a combo of surgeons to internal med docs? Is there anesthesiology? Is there intensivists? How does that work?
Sure. So palliative care is such a cool specialty. First of all, it as a field, that idea of palliative care again started in the 1970s, but as a specialty that's recognized by the AMA and the ABMS, it really wasn't finalized until 2008. And what is so cool about this specialty is that you can come up through there's 10 boards that sponsor the hospice and palliative medicine exam. So general surgery is one of them, but then there's also internal medicine, family medicine, anesthesia, emergency medicine, pediatrics, rad-onc, gynecology, and a few others. The number of surgeons that are currently board certified in hospice and palliative medicine is about 90. And I think that the vast majority, I don't know how many are currently board certified in general. I'd say almost 7,000. That would be my best guess. But the majority are going to be family medicine and internal medicine. But there's a really nice group that I've gotten to know of emergency medicine docs that are board certified in hospice and palliative medicine. And then there's some renal doctors and some cardiologists. And it's just like a real wide group. And you can really start looking at all the and peds and anesthesia. You could look at all the specialties and see the need. And like what I love is that all of these different groups bring something else. I have a friend who does anesthesiology and pain and then board certified in hospice and palliative medicine. You could bring like such an amazing skill set to the table, and certainly a different skill set than I'm bringing. And then I think of all the emergency medicine docs who do it. They're right at the front line. They're the people who, yes, look at this patient in the emergency department, say, you don't need an acute care hospitalization. You need to go to hospice. They can either come in and do GIP hospice in our hospital, or we're going to get you to a facility right now, and avoid that unnecessary hospital admission. And not just the bills, but the exhaustion that comes from the patient and the family of even being admitted. It's so exhausting. So it just really, I think to me, it's such an exciting field. One, because there's so many different minds in it. And two, because it's so young and it's like so ripe it's still growing and changing and defining itself, which I think is just great.
Yeah, I had my mind opened to it as well. Even a few years ago, I worked with an ER physician. We were together and she said, yeah, I'm going to do a subspecialty in palliative care tied with emergency. I'm like, really? How does that work? And I'm like, yeah, it seems like a no-brainer because we're in a small community hospital. That she's like, because there's no access to that around here. And people, exactly what you said, they hit the ER, they're end stage. They don't really need the bill. They don't, and she's like, I have a heart for this. And I'm like, that totally makes sense. We tend to, us old school trained and patients, they tend to think of, it's like the family doc, perhaps some peds. But you never tend to think of all these other people that would have just great different things to bring to the table from their expertise and training, all the way down to, you're right, the radiation oncologist. Heck, they're dealing with it, death and dying and mortality continuously. So I think that's totally awesome. And that even just having all these different people to help families and patients brings so much more, like Tim said, richness to it's life and death, the circle of life, or however you want to say it.
Well, it is. And, this is BS free MD. And so, and largely our mission is to call BS on ourselves or on our profession. And, it's always driven me crazy that there's sort of this unwritten rule in Western medicine that somehow no one's supposed to die,
Yeah.
and like you see these, you see these advertisements for, some of these, newer chemo agents, and like I'll freeze it and I'll make May read the bottom, and it's like 90 days. People are getting an extra 90 days with their metastatic lung cancer. And then you can't find the prices on this stuff. I had a connection to our hospital pharmacy, and like Optivo is $18,000 a month for 90 days of dying. You get an extra 90 days of dying.
But
now I've seen patients.
I would counter that. I would counter that by saying one thing that I love about the practice of palliative medicine, whether you're boarded in it or not, is talking about that idea of goals of care. Because, depending on who that lung cancer patient is, I always say, if you're young and have young children and all you need is time, and, that's the only thing you need is more time with them, then I want to give you I want to support you in getting those 90 days. But, the problem becomes we're offering these treatments to people who are 70, 80 years old, who oftentimes sometimes have an ECOG of 3, and they shouldn't be getting anything anyway. And then really, and have we really had that conversation? Really, what's most important? Is it time because you need to see your granddaughter get married in a month? Or should we really be focusing on quality? So it's I don't want to rule that out, because sometimes all people want is time. And, who am I to say? I might not want that time, but someone else might, right? But I think
Right. And
I hear your point that most of the time we're not even asking that question, and we're just kind of giving it.
well, and that was my that was kind of, I think, really
I think that was
underneath what I was saying.
And I know that from our experience in the past and from years of practice, we would get frustrated as family docs, being the quarterback for the team and the family, and people would come back from oncology, and it's just you got this, okay, we need to do this, and without sitting down and saying, these are the odds, these are the numbers, this is how much time, this is how much you won't get, and people they just have false hope. So I think that's what's driving a lot of Tim's frustration with some of that. Is that it's the false hope, and without patients understanding, is it giving them time for something, or is it just this false hope that it's a cure versus?
Well, but we have proof of that. I mean, there was a New England Journal of Medicine article that came out about 5 years ago. People with end stage colon cancer and end stage lung cancer, so two very common cancers that kill people, and it was 90% of people thought that their essentially palliative chemotherapy was curative. And it was 90% in lung cancer and 95% in colon cancer or something like that. They literally thought that they're getting chemo because the chemo has a hope of curing them, and it's well, no, you have a surgical problem. I mean, if we can't cure you surgically with those cancers, then there is virtually zero chance the chemo is going to do anything but give you time. Now, I have seen people have wildly successful life extension with very few symptoms for lung cancer. They got an extra year and a half, maybe 2 years, and then they passed away and they had tremendous quality. So that is changing. I also understand the average of 90 days is part of the BS of randomized controlled trials, where they put everyone in a bin, and some, how you get to the 90 days is some people might have lived an extra year and other people might not have lived an extra 10 minutes. But, that's
right.
So there's a lot of sort of bullshitology that goes on in randomized controlled trials, because they don't really reflect real life, but they kind of give you an idea of what's going on. So I see that too. But it's the conversations. Clearly, when you look at that study from the New England Journal, we're not having those conversations as a profession. We own that,
We're just awful at it. There's a study I was reading recently too, talking about communication. It was looking at surgeon communication in the ICU and how well surgeons speak about prognosis. And there was basically, the researchers asked the surgeon, how well do you think you did? And of course, 90% of surgeons think they did great, because that's who we are. And then they asked the medical intensivist, well, how well do you think the surgeons did? And I think about 23% of the intensivists thought the surgeon did a good job. And then they asked the ICU nurse, and 3% of the ICU nurses thought that the surgeons really were able to clearly explain the prognosis to the patient. So I would say we all have a lot of work to do,
Interesting. I mean, yeah, it's all our perspective and how whatever our field is, do things and what we think we're bringing to the table. Yeah. Wow.
No, and that's sort of my defense of generalists is, somebody needs to have the big picture. It's not just expensive chemo or unnecessary procedures or whatever. It's down to cholesterol pills. I mean, I'd see people that are 95 years old and they're on cholesterol pills.
Yeah.
And I'm like, I had this one lady. She was just a delightful English lady. She came in, she still had an English accent, lived in the United States for probably 70 years. And she's like, I said, why are you on cholesterol pills? Well, I don't know, because my doctor told me to be on the bloody cholesterol pills. And I said, honey, you should be on cigarettes and whiskey at this stage. It really doesn't matter.
Yes.
You've lived a tremendous life. You're sharp as a tack. You don't need I said, what are we trying to prevent?
What are we preventing at this point?
Yeah.
I know.
And it
I feel
was just
these
wild.
people.
And then I had another lady I saw when I was doing a locum. It was spectacular. She was, I forget, like 92 or 93, still really sharp and still smoked.
Oh.
And, of course, we would get dinged in the metrics if we didn't counsel her on quitting
Yes,
smoking.
exactly.
And I'm like, I told her, I said, honestly, I'll buy you the Camels at this point. Like, it doesn't matter.
Right.
But
And
you
I
ticked the box. You ticked the box that
Right.
said you canceled
but,
her about her
the
smoking.
best story ever was how she started smoking. I said, when did you start smoking? Well, I was 18. And I lived in Paris. And the American GIs were marching through Paris. Were just a few years before the Nazis had marched. And they had liberated my city. And they threw out packs of Chesterfield cigarettes. And I never quit.
Wow. That's amazing.
My gosh.
Oh, that's so
I'm
good.
like,
Yeah.
yeah.
Oh, all kinds of fun stories,
Oh, yeah.
man. Collect more and more.
It's amazing.
So, you have started a podcast on surgical palliative care. Has it been 2 years? Is it been 2 years now? Did it start? I think last year in 2020,
It
right?
started in 2020. Yeah, so a little over like a year and a half ago now. Yeah.
So tell us about that and how that got started. What was I don't know, what was driving you to do more things if you weren't busy enough doing trauma and palliative care to do the podcast?
Yeah. I felt like when you're a surgeon interested in palliative care, it's kind of hard to know where to turn because the field of those who do surgery in palliative care is pretty small. So I really wanted to use it as an educational tool. But two, I was feeling like there's so many founders of surgical palliative care and then palliative care in general who are getting a little older. And I felt like we really needed to have that audio record of them. And so my first guest was Dr. Balfourmont, and he was just on my podcast again last week. I mean, he's in his 80s and he's had 3 primary cancers. So, I was like, I got to get this man on tape before we lose this beautiful history. I mean, he's incredible. And so those were some of my reasons for wanting it. And then also just I love podcasting, and as I was talking about before, I really love editing. Like it just works on a different part of my brain than my job does, and so it's something I've really
part of your brain.
it's really something I've grown to enjoy, and it was so fun to pick up a new skill and figure it all out. Has just been really exciting for me. So it's a definitely a niche podcast, but I've been very blessed in that everyone I've asked to be on it has said yes. And so I've interviewed Diane Meyer, who's the founder of the Center for the Advancement of Palliative Care and has really brought palliative care. I mean, she's done the most really to bring palliative care to the masses. And then Ira Byock, who's an incredible author who's written multiple books. And has really been a spokesperson for palliative care. And then so many people in the field of surgical palliative care, Jeff Dunn and Mosenthal, Gretchen Schwarzy, like all these people who've done so much to integrate high quality palliative medicine into the care of surgical patients. So it's been so fun. I love it.
Yeah, we love podcasting. It's super fun. You get to meet so many people. And obviously, yeah, what you're doing is, I mean, that sounds so exciting having the founder on there. Exactly what you said, just to get it in audio. It's going to be like the Harrisons of textbook of medicine. Now your podcast on palliative care and a great resource. And obviously, yes, very niche down. But I think anybody probably in the palliative care world and even physicians in general or any healthcare workers involved in that find a lot of really great stuff on there that would be helpful. Other
Yeah.
than the
Yeah, and
I was
I've
gonna
been
say
able,
other than
I've
the
had some great sorry. I've had like 2 pharmacists on there, a palliative care nurse, a chaplain, really because palliative care is such a team sport. So I really think it's important to highlight all of these team members who are doing great work, for surgical patients and then for patients in general.
Yeah. Hey, so I know that there's the Surgical Palliative Care Society that you helped found. I mean, tell us a little bit about that. Is it pretty new? How long has it been around, and is it part of the does it start after the podcast, or how's that all connected?
Sure. So again, it really was, the idea of it was born, I think, at the American College of Surgeons Clinical Congress at a small dinner in October of 2019. And, it started with a bit of a larger group, kind of whittled down to myself and two of my colleagues, Dr. Pringle Miller and Dr. Buddy Marti, are both surgeons who are board certified in hospice and palliative medicine. And we worked for about a year and a half to get it started. I mean, I've never started a surgical society before. So it, again, talk about a learning experience. It was so interesting to figure out how to get a manager for this and how to become a 501(c)(3). And then we're still in the middle of building our website. And then we kind of launched it into the world last month. So now we're still looking for people to join. And the idea of this society is, again, a place of mentorship for young surgeons coming up who are interested in hospice and palliative medicine and how it looks to integrate that into their clinical practice. But the other idea of the society was also to be truly interdisciplinary. So you don't have to be a surgeon to join. Anyone in medicine can join. And we really encourage people who are like palliative care nurses, palliative care social workers, chaplains, pharmacists. Anyone who's interested in delivering palliative care to surgical patients is welcome to join. So we're still trying to build up our membership so that, because we have all of these leadership positions that need to be filled, but you have to be we'd like you to be a member to be a leader. So we're still at the very beginnings, but I feel like, in 2 or 3 years from now, this will be a thriving organization. We're going to have a meeting every year, kind of in conjunction with the American College of Surgeons Clinical Congress, once it comes back into, the real world rather than virtual. So our first real world meeting will be in October of 2022, hopefully, where, not only we'll have speakers, but also looking to showcase research. And again, just to have this like collegial support. And I want to mention one thing I love about this society, because palliative care is such a team sport. And surgery is also a team sport, but there's a real hierarchy in surgery. Whereas in palliative care, it's really this interdisciplinary team, which means that it's not the doctor who's in charge. Everyone gets an equal say in what's going on. And so we really structure the leadership of our organization in the same way. So we don't have like a president and a vice president. We just have a council, and then we have committee chairs. And part of this was based on that interdisciplinary team, but also Buddy Martyr is a beekeeper. And that's apparently, it was kind of modeled after how a beehive works, which is there's really no one in charge. And that hive mind tends to be more creative and often more focused than an individual mind. So it will be very interesting. I'll tell you, even having a hive mind with 3 people is really challenging. Everyone I think in medicine in general tends to have strong personalities and strong opinions. So learning how to play well in the sandbox that's a challenge. And it also takes a lot more time. It's way easier for me to say, this is how it's going to be done, but that's not how we want to do things. We really want to, encourage everyone's voice. And
that sounds difficult. I mean, as just exactly what you said, because strong-minded individuals trying to play equally. I don't know about everybody else, but the hive always has a queen, and where the queen goes, the rest of the bees go too. So, I mean, I hear what you're saying. I think it's important to have that total balance and say, but yeah, I mean, I just think you don't want to waste all those good energies tugging on fighting for authority. But I think ultimately it comes down to what we're doing for patients, really, and doing the best by the patient that needs the palliation. So this is a really cool model.
Right. But the model works in a different space than another model.
Yes.
Like you don't want a hive mind in the OR.
Yeah.
You don't want to ask the
right.
anesthesiologist.
No, you don't. It's not appropriate. Right.
Yeah, no. And that's why I said, ultimately it comes down to serving the patient and the families in these situations. So that's a really cool concept. I really like that a lot. So where
Yeah, well,
I
we'll see how it
was gonna
works.
say, where anybody that's interested in joining, where would they go and find information on the society?
Sure. So you can go to our website, which is www.spcsurgicalpalliativecare.society.org. And then we're also on Twitter at spcsociety.org, or you can just contact me directly at redhoffman@gmail.com if you have any questions. But I'd really invite everyone, and membership is free for medical students, residents, and fellows. So if you're listening and you're a trainee, just come and join us.
Perfect. What about your podcast? Where are you? Are you on Apple, Spotify, anything else?
I'm on
Pretty much
Apple,
everywhere.
I'm on Spotify, I'm on iHeartRadio.
Okay.
And then that Twitter site is at SurgePalCare. But yeah, you can find me on Apple Podcasts or wherever you listen to podcasts.
And I'm going to link your website too, for people to find you and all about you. And I know that you've written some great articles. You've written about your sort of journey and your history that you shared with us about your father's tragic death and how your career sort of bloomed. And I just love your website in general to look at. It's beautiful. I think
Thank
it's
you.
just artistically pleasing along with all the content in there. So I will link that in the show notes too. Um,
Thank you.
so I'm thinking, man, we could talk so much, but is there anything else that I guess we didn't touch on, or that you'd want the listeners to, people to know sort of about what's happening in what you're doing, balancing everything? I can't imagine. And in surgical palliative care, I don't know, any last words or thoughts or anything like that?
Sure. I think, again, I would just reiterate that I really always want to just put that message out there that you don't need to be board certified in hospice and palliative medicine to do good palliative care or to do good end of life care with patients and their families. I also feel like I've walked into many situations where you can tell that the family is, or the patient, if they're awake, that they're suffering and that they want to talk about these difficult things, but they don't have the words or they're scared to bring it up. So I really do feel like it's our job to bring up these difficult conversations. And that when we come from a heart space, oftentimes, I don't know, I'm not a perfect communicator on any level, but I think people can see when they're sitting with me that my heart is open and I really do want to help them. And so you don't have to be perfect at it. Like, you could just start having these conversations and then you get better with time. And then I always say, like, the best way to learn is to just watch the palliative care team. So, like, if you consult palliative care and they're going to have a family meeting, go sit and listen to the family meeting. Because if you listen to a couple, you can see it's the same basic communication skills over and over. And then you can do it too. And so I just really want to empower people to feel like you don't always have to consult palliative care. You can do this work, and then if it doesn't work, then consult them. But a lot of times it's low hanging fruit that can really be solved with a conversation or two.
Yeah, I was going to say it's something that I always forget, I guess, because I just take it for granted of what we've done in Tim and I in our careers as family practice doctors. It's a part of like life, that's sharing in the joy of like being at a delivery, and then literally in the next minute we could be running down when we did ICU to being there with patients that are dying. And it's, I always say it's just fascinating how privileged we are to be able to walk through people. I'm going to start crying, from their
Yeah.
joy to their grief, and share all of that with them. I mean, just silly things that I always say. People come to us and in 10 minutes they take their clothes off in the office because they trust us. But it's just such an honor and blessing to do that. And that's what life is just walking waist deep through humanity with people. And it's a total honor. And I think that anybody in medicine just would grow as a human, just to be involved in just holding people's hands and sitting there with them through death and dying as well as the joy. So thanks so much
To
for
me, it is the best antidote It's the best antidote for burnout. I mean, to be truly present in these moments of joy and in these moments of pain, and it really helps me like love my job. I'm not saying it's easy on the soul all the time. You definitely take this home with you sometimes, but really just remind you of like, God, we are so lucky to do what we do.
Yeah, and to reiterate that, I've said this I don't know how many times. Hard work does not cause burnout. I don't, we're physicians. We're hardworking people. If you weren't hardworking, you'd never get through medical school. So hardworking people don't get burned out by hard work. They get burned out by meaningless work. And clearly you're bringing the meaning back to your career, to your life, and to other people's lives by relieving their suffering. I mean, it is the lowest hanging fruit of medicine. It isn't curing the sick. It's relieving suffering. And and suffering isn't just physical, it's emotional, it's spiritual. And so to be able to be there, to hold hands with people, to cry with them, to pray with them, to really, connect in a way that we have a unique privilege as a physician is, really what we got to remind ourselves. I mean, I know I do, because you get so stuck in the corporate bullshit that you're just like, I'm done. But I'm not done, because I still got a lot to offer.
Yeah.
Right. Yeah, it's just the best.
All right, Red. I'm so glad we got this done and you were here and we got it recorded for everybody to hear, and they're going to love it. Thanks again for being here today.
Thank you so much for having me.
Have you back again in the future with so much more to talk about. But until then, take care and thank you so much for what you do.
You guys are awesome. Thank you. It's so great to see your faces, and take care of that knee. Bye.
Wow, that was just great. I love talking to her. She is so passionate, and she obviously really cares. And it, the thing that just kept hitting me was, all this talk about burnout, to actually see a doctor who loves what they do and is really, immersed in the healing arts. It's great. I mean, sometimes I think we talk so much about burnout. It's like you have to have it or else you're not one of the cool kids. And actually the cool kids are people like Red, who can throw their entire heart and mind into their career and help so many people. It's just awesome.
Yeah, and I really like the how she touches on the importance of balancing out all aspects of not just Western medicine, surgical medicine, but the Chinese, naturopathic, all aspects of caring for patients. So really fun to learn about that. I will link all the websites, her podcast, and society notes in the show notes as well. And just to reach out, we are looking for new sponsors. So if you know anyone in the medical world that would like to sponsor such a cool show as this, they can reach us at doc@bsfreemd.com or on any social, I guess, as well.
Yeah, I'm sure we're going to get a sponsorship from the NIH and from Fauci. Well, that's probably going to happen.
Thanks this week to our sponsor, Locum Story. Remember to check out drpodcastnetwork.com/locum story to see if a locum tenens assignment is right for you. It's here you'll find the unbiased answers you are after, so you can decide if locum tenens is your next chapter. Like us, share us, rate us on your favorite podcast network, and we'll see you next time.
It's no secret that medicine is a bit uptight. That's why Tim and I created BS Free MD, to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS Free MD. See you next time.
While we try to keep BS Free MD as raw and real as possible, we can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know. Bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bsfreemd.com.
Maybe the Trump organization can sponsor.
Show's huge. It's a great show. Best show ever. Great doctors. Amazing doctors. But remember, eat less blubber.
So then we're going to keep talking so it doesn't cut us
we
off.
have to keep talking so it doesn't
Blubber.
cut us off. I think that should just be a blooper.
This.
They should just
Got
cut that out.
diabetes because you're fat and you have too much blubber. Need insulin because you're huge. Huge with
Okay,
blubber.
I think that's enough talk.
Too much blubber.
Just cut them off.